Good morning, future PTAs. I hope you guys are doing well. It may not be morning right now where you're watching it, but it's morning here. And we are going to talk about transfers today. So transfers are in your mobility and context book with throughout chapter 8, 11, and 12. So we will actually cover all three of those this week in lab. But today we will just learn about chapter 8, and the other two chapters we will cover in lab. Okay, so our overview is what we will be covering, kind of our roadmap, the risk involved in manual lift, standard equipment, safety, and patient handling and mobility, and then our special considerations. So let's start out with the risk. Sorry, I have a thing in my way. Okay. Now I can see the whole screen. Sorry about that pause. So lifting and moving patient increases your risk of injury, especially low back and shoulder injury. So we've talked about this before. The risk is affected by how much force is required, so kind of how large the patient is or how much assistance they require. By repetitions, how often throughout the day you're moving patients, and by awkwardness of posture. So proper biomechanics is kind of the combat against the awkwardness of posture that would cause you to get hurt. And then chair to toilet transfers are typically the most stressful. They're the ones that are going to cause the caregiver to be most likely to be injured. So you have to be especially careful there. Safe patient handling and mobility policies. These are things that came because so many caregivers and healthcare workers were getting injured. So OSHA, which is Occupational Safety and Health Organization, began releasing policies just stating how to handle a patient in order to minimize the manual lifting of patients, so use equipment when possible, and try to minimize injuries was really the overall goal. But the policies basically are how to safely handle, and also the need for the specialized equipment and using those when possible. So the more dependent the patient is, the less they can help you, the greater the need for a mechanical device, some type of assistance other than just your brute strength. And then there are legal requirements in many of the states. Texas was kind of the leading state that passed requirements for all hospital and nursing facilities. And they decided that each one had to establish policies on safe positioning and handling, just because there were so many people getting injured. And so now legally they have to have those policies in place and follow those policies. Of course, the caregiver can get injured, but the patient can get injured as well. So that's another concern of making sure they're safe. And then therapists can manually assist in mobility as part of rehab intervention. So not only can you use these devices just to get them from point A to point B, but you can teach the caregiver how to do them. That's part of our education, patient and caregiver education, but you can also use them therapeutically. So we'll get into a little bit of that when we get into standing transfers and talk a little bit more about that. All right, there are dependency levels and recommended lift assist. So these are not, like we talked about in class, the assistance levels, like how much assistance you're providing. This is dependence levels. And so that is how much assistance they need, how dependent they are on somebody moving them rather than being able to help. So it's not the min assist, mod assist, max assist we've discussed in class. It's level 0 through 4, with 4 being the most dependent, a total dependent person. They need you to do everything. They can't help with any of it. And 0 being someone who's independent. They are able to do all of it, and you really don't need a mechanical assist if they can do it themselves. So the level 4, if they are totally dependent, then you do not need to lift them yourself, if at all possible. Now, in the pediatric population, you see a lot of people still lifting them themselves, somebody that's smaller, but ideally you would have a manual lift for somebody who is totally dependent. With a level 3, they need extensive assistance. So they're able maybe to move their arms out of the way. They may be able to help a little bit with moving their leg or something, but they require extensive assistance. In that case, when possible, you try not to manually lift the patient, but use a sling or some type of a stand lift or Hoyer lift. We'll go into all those types of lifts in just a minute. And level 2 and 1 have limited assistance or supervision. So there's a big gap between, or a big area covered in a level 2 or 1. They are able to assist with the transfer, but they still need assistance from the caregiver. You could use a manual or a mechanical lift, but you could also, I'm sorry about the yawn. You could use a mechanical lift, but you could also use other techniques. Manual technique like we'll learn in class, but also transfer boards. You could use their assistive device, possibly. You definitely want to have a gait belt on that patient and use it as a therapeutic technique so that you're teaching them to be as independent as possible, not just moving them yourself. And if you want a little more detailed explanation of these, it's in box 8-2 in your textbook. So you can look there. Okay, so some of our standard equipment, there is a hospital bed, a standard wheelchair. With the hospital bed, it can allow patients to do positions they couldn't do in a normal bed. So Fowler's position is what is pictured here, where the head of the bed is raised and the feet or legs are raised as well. Trendelenburg position, the bed is flat and the head is lower than the feet. Those are positions that are really hard to do in a regular bed. But it also has the capability of changing the height of the bed, putting bed rails up to help move around in the bed. There's brakes. You can move the bed when you take the brakes off. With a standard wheelchair, there are push handles in the back. You will have your wheels and your, I just learned that in a second. The smaller wheel has a separate name. I'll tell you that in class because it's in my other lecture that I just did. And then there are armrests, which typically come off. You can take them off for transfers. There are footrests, which also they swing out and they also can be fully taken off. And then the locks are also called the brakes, and they stop the wheels from moving, which you need before you take them or transfer them in or out of the wheelchair. All right, vertical lifts, total body lifts and standing lifts. So total body lifts, typically you will need a powered ceiling hoist or a portable floor base, which we call a Hoyer lift. There are manual Hoyer lifts and there are battery operated. So the manual have like a crank arm that you crank them up. The battery operated, you just push a button. And then there are hybrid lifts that are freestanding with overhead frames and tracking systems. So we are about to go into more detail about these lifts, but these are the types of total body lifts that are available. So indications why somebody would need a total body lift. Yeah, point-to-point transfer. So if you're just trying to move them from point A to point B, they may need a body lift, but it also may just be more convenient to just pick them up and move them versus taking 30 minutes to get them in the right position and teach them how to move themselves. So if you're just trying to take the patient to maybe a special imaging or something, a test that they have to leave the room in a wheelchair for, then you might go with it just for the ease of time and convenience. If they have non-weight bearing lower extremities, so they're either not allowed to place weight on them or they're not able to, maybe in the instance of a spinal cord injury, they're not able to bear weight on the legs, then you could use a total body lift. There's other lifts like the seated lateral transfer we'll learn later as well, but the total body lift might be the best option for them. Okay, so if we are doing a bed to chair total body lift, the main thing we need to do is make sure the sling is properly positioned under the patient. So the bottom edge of the sling is near the sacrum. You make sure you smooth all the wrinkles out. Transferring a patient with wrinkles under them could cause skin tears, those shear forces we've talked about. And then position the leg straps. So oftentimes we will cross them under the legs, and so then they go under the legs and cross to join into the lift so that it's a little bit more secure. If the person is able to just sit up, or like they can pull themselves up with a trapeze bar, then all they do is lean forward and you position the sling. If they're not able, then you could have them roll to one side and position the sling halfway under, roll back towards the opposite side and pull it the rest of the way under and just make sure it's wrinkle free. We practice that with a sheet in lab, so it's a very similar technique. Okay, so then you attach the portion right here, this gray portion that she's attaching the hooks to is called the crossbar, and you want to attach the sling to that crossbar before you lift and move the patient. So the portion of the sling that gets attached are called the D-rings, and they go directly into the crossbar. And then once you get them positioned correctly and hooked in and begin to lift, just be very cautious and careful that you don't accidentally hit their head or their legs against either the overhead arm part of the lift, any part of the lift really, or nearby objects. So you want to make sure you're looking exactly where you're going. Sometimes it takes two people just for that. One person's moving the lift, the other person is controlling the patient so they don't accidentally bump into something and get hurt. Okay, once you start to move the patient, you try and position them directly over the chair or the bed. If you're moving right now, we're doing bed to chair, and then lower them into the chair. After you position them, you can pull the handle and have them, because typically they're positioned or they're moving in a reclined position, but there's a way that you can kind of reset the handle and pull them up into more of a seated position. And once you get them upright, you can slowly lower them in the chair. And as they're lowering, you may need to reposition them, scoot them back over, sit them up a little bit higher in the chair as they're lowering, or once their butt hits the chair. It's much easier to reposition when they're still connected to the lift and it's taken some of the weight away than it is to walk away, or not walk away, to get them fully out and then just manually position them. So it would be better to get them started in the right position with the mechanical lift than to have to use your own strength to put them in the position. All right, a total body lift, we're trying to go from the floor to the bed in this instance. So again, you make sure that the sling is under them, and then you wrap it correctly. And then you connect it to the lift. This lift in particular is called the ceiling lift. So rather than the first one over here, that was a floor lift because it scoots around on the floor. This one is connected to the ceiling, so it stays in place. It's ready for any patient that comes. You may see some of those in specialty hospitals, but if you're in, a facility that doesn't get a lot of dependent transfers, then you may have to find the floor lift and move it into the room for that patient. So then you will, again, be very cautious about moving the patient. Make sure they don't hit anything. Get them directly where you want them in bed. If you need to scoot them up or back, then try and do that while they're in the sling, and then slowly lower them down into the bed. Anytime you're moving a patient, you want to cross their arms across the chest so they're not just flailing. In these types of slings, there's a lot of coverage, and so their arms are typically stay inside, but there are some slings that are slightly smaller that their arm may fall out of the side, and then that arm's more likely to get injured. That's not what you want. And typically when somebody needs this much help with transferring, they can't move independently very well, and so they're at a high risk for skin breakdown if they're just laying in bed most of the day. And so make sure you have what you need, protective barrier, whether that's a slippery sheet or whether it's what we call chucks, which are those square pads that are absorbent if they were to pee or whatnot. Make sure that the proper things are in place between the body and the patient. The patient and the bed, the surface you're transferring them to, and the patient, so that their skin is protected. Okay, so there's a few more things that make the transfer safe for the patient and the clinician. Notice in this picture, the bed rail is up on one side, not on the other. So the side that you're coming through, you don't want the bed rail up or it will be in the way, but the side that is opposite of that, you want the bed rail up to protect them from falling out of the bed. They can also grab it to assist with the movements. The floor lift is positioned perpendicular to the bed with the base of the lift underneath the bed, which minimizes the distance between the load and lift. Let me show you what I'm talking about, because with the ceiling lift, you can't see that. Of course, the patient is in the right position that you're moving them towards, but the lift itself, see how it's perpendicular to where you're wanting them to be. So if it is a bed, let me see if it shows, it doesn't show the base there. Then you would have it, I'll show you in class, I can't explain it very well, but the Hoyer lift, if the bed is this way and this is the way you would lay down, the Hoyer lift, the arm of it would be perpendicular to that, and the base would be underneath the bed. Here it's kind of straddling the chair if you're using that type of lift. The other things, the crossbar is well above the head. You want to make sure so that their head doesn't bump the crossbar. Some of the older lifts, there's not very much room between the patient's head and the crossbar. The newer, you shouldn't have that as an issue too much. And then the base, when it's a floor lift, you can narrow it and widen it depending on the space that you have available. So maybe widen it to get it around a chair, narrow it to get it in between the wheels in a hospital bed. And if you don't readjust the patient's position before you put them in the bed, they will be slumped. So make sure you reposition them before you sit them down in their chair or bed, because the position of the sling itself gets them in kind of a slumped position, reclined position. So you don't want to just leave them in that position. It's not best for their body. All right, with sit to stand lift, this is more of the one I was talking about. We could do some functional training with, maybe some reaching and things like that. This helps them move from one seated position to another through standing. So sometimes you can use it in therapeutic, but you could also use it just for a transfer and not even keep them in that standing position long. But if you do have them standing, you can do reaching tasks. You can do a little bit of balance type activities in the standing position, core training and things. And it's really good for toileting or perennial care, because then you can lift them up, turn them to the toilet seat or wherever, and sit them down pretty easily without the sling underneath them. The patient does have to do at least partial standing for this transfer. So if there are weight-bearing precautions or they're unable to stand for whatever reason, then this would not be the transfer for you. All right, and basically the biggest difference between the design of this lift is that there is a plate in front of the legs that keeps them from going forward. These arms pull them straight up. You'll see in the next picture. So go to the next slide, and they're easier to maneuver in small spaces. Right here. So this is the standing lift. So you have the sling that's around right here. It's just around the upper back. It should really be a little bit lower than that. So it covers part of the upper back and part of the low back. And then the block in front of the lower legs to keep the knees from buckling. So the things that need to be in place before you even try a standing lift like this, they need to be a level 3 or 2 assistant. So if they're completely dependent, then this is not a good transfer device for them. They need to be able to bear weight through their legs. They need to be able to flex their hips, knees, and ankle, as well as extend them to a certain amount. They need to be able to maintain sitting balance without extensive support, because although the knees and the legs are supported in the right position, there's not a huge amount of trunk support, so they need to have enough trunk strength to sit at the edge of the bed or something without just flopping over, or they wouldn't be able to maintain an upright position with this lift. And then if they have significant back problems, you may not want to use, because you want to avoid exacerbating those problems, making those worse. With this sit to stand lift, of course, you apply the sling. It needs to be covering part of the upper back and part of the lower back. And then you connect the straps or the rings to the device. You make sure their feet are on the platform to stand on. Okay, all those things I said that are below, I just want to make sure I covered all of that. And then you activate. So again, you might just push a button and it slowly lifts, or you may have a manual lever that you have to kind of pump to get them up. And the patient stands. So the sling is supporting the back and the plate here is supporting the legs. They can hold on to the handles, and you do want them to hold the handles while it's moving. Once they're up in an upright position, you may be able to have them release the handles to touch your hand or grab an object or reach and do functional training. And in the chapter, it did say people with weight-bearing restrictions may be able to still use the lift. You just have to be really cautious. I would be very cautious with somebody with weight-bearing restrictions. So as long as they can fully bear weight on one side, they may be able to bend the other side or do something to take less lean away from the side that they can't weight bear on, in order to put less pressure on that side. But just be very careful and watch them very closely if they do have weight-bearing restrictions, because it would be easy to break those restrictions in this lift. Okay, lateral transfers are another way to move a patient from one surface to the other. Typically, these are in horizontal adjacent surfaces. So like from one hospital bed to another, or from the hospital bed to the gurney or the stretcher to the portion that, so think about in the ER, you come and you're in that long bed that moves, or you're on a stretcher, and then they roll you to a bed in a room, and then they slide you over onto the other bed. It could be onto a surgical table. It could be any lateral surface. They would use this lateral transfer technique. Some of the equipment they could use, the slippery sheets and draw sheets, are similar to what we saw before. I think I have another picture of them lower, but they just decrease the friction between the skin and the surface to keep it from shearing. There are air-assisted devices, so this would be an air-assisted device. It's kind of like a small blow-up mattress. Most of them are a little bit longer, and they have straps so that you can easily pull the patient from one surface to another, especially ideal for a larger bariatric population. And then there are rigid or semi-rigid transfer boards. So you see right here, this is a rigid board that you roll the patient onto and then slide the entire board with the patient on top of it to the next surface. And so any lateral transfer that is performed, the patient needs something to decrease friction between their body and the surface. So you don't just scoot a patient with their gown on exposed in the back from one surface to another. You either use the sheet to scoot, you use the air assisted device, or a rigid transfer board. You do not just scoot them. That causes too much friction. Okay, so lateral transfers, procedures that typically require 2+ people. You place the device under the person, you lower the bed rails, you scoot the two surfaces together and make sure they're stable. If there's locks on, one of the beds that's moving, then make sure both of the beds or surfaces are locked and in place. Then you grip either the handles or the sides of, if it's a sheet or something like that, you grip the surface that you're moving, and you set your abdominal muscles. Remember, you kind of contract like you're about to get punched in the stomach. You bend your knees and you scoot the patient on the count of 3. You need 2 people. You need to communicate, work together. And once you get them to the new surface, the main thing is making sure they're safe. They are in a good position. You put the bed rails back up, give them the call bell, have a way for them to call for help if they need it. So right here, the clinicians are standing at the head and foot. There's different ways that you can do lateral transfers. Right here, they're doing the head and foot, where they are able to move the person with the slippery sheet under the person. But here are 2 different examples. So here they're using a rigid transfer board, and they're on both sides of the patient. You just have to be really careful when you're moving it this way, because it's a more likely position to get injured in for the clinician. So sometimes the clinician will get on the table with the patient, and you may even do it in phases where this person over here is standing on the floor and the person they're coming towards is on the table. And then once they get a little bit further, the person that was on the side they're going away from has to get on the table with them, and the person they're going towards may have to get off at some point. It will, in order to make room for the patient. So you can kind of do it in stages. You don't have to do one fluid motion by any means. A transfer board is easier to accomplish this method than the slippery sheet. And one of the tips it said was to do the golfer's lift, where you extend. Okay, so this person says the clinician on the right is doing it. Extend one hip and flex the trunk in order to maintain a good spinal curve. I think it's below maybe the next slide, it also mentions that you bend your knees and place them right against the surface of the bed. And so then whenever you have to straighten your knees to push or to pull or whatever, you are kind of anchored into a surface, and it's helping you push and resist against that. So I think that's a good idea as well. And always keep in mind, you want yourself and the patient to be safe, however you choose to transfer them. This is just placing the slippery sheet under the patient. Like I mentioned earlier, you can fold it or roll it together and roll them towards one side, place it under them, and then roll them over the sheet and straighten it out. The main thing you need to make sure is that there's not a lot of wrinkles under them. Straighten those out. And I've already talked about all this. Sorry to have another one. But in this picture, the second picture, they are moving him up in bed. So you can also use the slippery sheet to move them up in bed. And once you do the lateral transfer, you do want to make sure that at the right height in the bed, because what you don't want is them to be too low or too high. And when they go to lift the head of the bed, they're in a weird position, because that can put extra strain on areas that are likely to break down as well. This is that air-assisted device. This is the one I told you was kind of like an air mattress. And you can often do a one-person transfer with that if the patient is small enough, because it really de-weights the person. It slides easily, and you have handles to grab onto, straps that allow you to easily slide it. Okay, the air-assisted devices typically don't have a weight limit. A lot of our transfer equipment does have a weight limit, so you need to be extra cautious about that if you have a larger patient. But if the air-assisted device is more narrow than the patient, then you need a different device, because it will not provide the de-weighting of the patient that is necessary. Okay, and then with transfer boards, this is where I mentioned pushing against the bed. And you can also use them to scoot up and down in bed. But of course, once you get them to the surface, you need to have them roll to the side, and you need to remove the transfer board from the patient. You don't leave them on a rigid transfer board. That would be painful and likely to injure the patient. Factors affecting lateral transfer methods. So what would affect how you transfer the patient, whether you use a Hoyer lift or a transfer board or whatnot? Their weight, the musculoskeletal complications, if they're able to move or not, and they're in pain or not, where. The distance being covered. If you're moving to two surfaces right next to each other, it's one thing. It's totally different if you're moving across the room. Their psychological condition, if they have fear or they are paranoid or had maybe a recent brain injury and confused, agitated, something like that, you may be careful about a Hoyer lift, because that might be very scary to them. They don't know what's going on, and then now they're in a little swing moving across the room, and they feel completely out of control. The width of the adjacent surface, so wherever you're going, if it's wide enough, depending on what equipment you're using, and then the need for head control. I'll put these pictures here for that, because this sling, as you see, it covers the upper back and the legs. There's no mid-back, I guess I would say it covers. There's no upper back or head support at all. So if they don't have head support on their own, this is not an appropriate type of sling for that lift. Whereas this one, as you see, the lift goes all the way from the back of the knees all the way up over the head, and so the person can just relax and not have to activate their own muscles. So for somebody without head control, you would need a sling like that. Anytime a person is poorly positioned, an assistive transfer device should be used. So if it's somebody that's a level 3 or 4, sometimes even a 2, just depending on their weight and the size of their body and things like that. If they need to be scooted up in bed, if they need to be moved in any sort of way, ideally you would want to use an assistive device rather than just muscling it out and using your own brute strength, because you're likely to get injured. Now, in some cases, that's not going to be available or possible, but when it is, you would want to use that. Make sure that you reposition using the manual or the lift if it's already on there, but you can also, once they are where they need to be, they can grab the trapeze bar if they have enough arm strength, that you can use a slippery sheet to move them up and down. And of course, there is vertical lift equipment as well. I'm so sorry about the yawns. I'm tired, and I know all y'all are tired too. So the total body lift we covered, the sit to stand we covered, and we covered the friction reducing lateral transfer devices. All of these can be used for seated repositioning too. So if somebody is in a wheelchair and they're all slumped over, you could use a body lift, you could use a sit to stand, or you could use just a slippery sheet or something to scoot them when they're positioned poorly in a seated position as well. Bariatric patients, remember bariatric is the obese population, typically morbidly obese. And so it puts the clinician at an even higher risk of injury. So proper body mechanics are even more important, and lift equipment is even more important, not equipment, important. But some of the equipment you need to look at their weight limit. So most of them will say extended capacity. If they have a larger capacity to lift larger patients. And if they don't say that, I would look and check for that particular piece of equipment, how much weight it can handle. You certainly don't want to get a patient in the middle of the air and it break. And then you may need more individuals. Even for a mechanical transfer where you're using a lift, you may still need more individuals to position and to help assist with that transfer. So always, when in doubt, yell for help. You don't have to yell, but. Okay, what factors related to each of the following will affect your choice for equipment? The task, the patient, and the environment. This is just something you can look over. It's in the slides, and below are some examples of each. So with the task, what you're doing and what the objective of the transfer, if you're doing it to teach them how to transfer themselves, you want them to do as much as they can. You don't want to just do a dependent transfer. Versus if you are just trying to move them from point A to point B to get them to a medical procedure, you may go for a dependent transfer. The patient, how well they're able to communicate, their cognitive abilities, and their physical abilities. Also their size and their precautions, all those things go into determining which type of transfer is the best. And then the environment. Do you have enough room for the transfer equipment? What surface are you moving from and to? Are there personnel around that are trained? Is there any special equipment needed or anything like that? So just kind of looking at what you have and what you need based on that situation will determine which type of transfer you do. All right, a quick summary. So manual lifting places the patient and caregiver at an increased risk of injury. So ideally, you only want to do manual lifts when the patient is able to assist you, or if there's maybe a emergency or something like that. Otherwise, you want to use a device to help you lift and move a patient. And make sure you follow all the safety guidelines for that particular device, because you certainly don't want to overload the system or hurt yourself or the patient. That's all for the Play Pause It for today. Let me know if you have questions, and I'll see you in lab.